My name is Alan Braverman, and today we'll discuss what is aortic dissection and who is at risk. This is part of the Aortic Diseases Awareness Week lectureship. I'm at the Washington University in St. Louis School of Medicine. Thank you for being here. Aortic dissection is a tear in the inner layer of the aortic wall, allowing blood to enter and separate the inner and outer layers of the aortic wall. And this process can weaken the aorta, leading to instability and risk of rupture, can cause malperfusion of branch vessels, leading to ischemia in any vascular bed, or can disrupt the aortic valve, resulting in severe aortic regurgitation and heart failure. Aortic dissection is not common, affects about 10,000 people in the United States each year. Aortic dissection is sometimes referred to as the great imitator because its presentation can mimic so many other conditions that are more benign and more common. And the symptoms of aortic dissection can be highly variable, from very catastrophic in onset to relatively minor, making it a challenge to diagnose in certain circumstances. While chest pain is the most common symptom, the pain can be in the back, neck, head, abdomen, can be severe, or it can be vague. And other signs include instability, pulselessness, and symptoms of malperfusion, or a sense that something is terribly wrong. When we think of acute aortic syndromes, aortic dissection is the most classic and is responsible for 80 to 90%. And in this cross-section of the aortic wall and lumen, there's a tear in the intima, allowing blood to enter and propagate. 20% or so of aortic syndromes are related to a primary hemorrhage in the wall of the aorta, known as aortic intramural hematoma, or IMH. And in this condition, we don't see a visible intimal tear. And about 5% of aortic syndromes relate to atherosclerotic disease, where a penetrating ulcer enters the aortic media and propagates with focal areas of hematoma and sometimes small areas of dissection and risk of rupture. A classic aortic dissection, again, is a tear in the aortic wall. So blood then enters into this false channel separated by the intimal flap. The dissection typically propagates anterograde down the aortic wall, but can go retrograde and leads to malperfusion syndromes, risk of rupture, late aneurysm, and other potentially catastrophic complications. This is a surgeon's view of aortic dissection, courtesy of Joe Bavaria from Pennsylvania, where the heart is here, and this is a massively dilated aorta that's thin-walled. You can see the blood circulating right through the aorta and the intimal flap going back and forth from the aortic root into the ascending aorta. You can see how dangerous this condition can be with a thin-walled aorta at risk for rupture at any time. IMH, or intramural hematoma, 10 to 20% of syndromes, you can see the blood in the aortic wall and the intima is intact. So a spontaneous hemorrhage of the vasa vasorum, or some people feel microscopic tears in the aorta, that presents similarly to a classic aortic dissection. That's called IMH. And a penetrating ulcer is where the aorta has atherosclerosis and calcification, and an ulceration occurs, leading to focal hematoma and risk of rupture. When we think about aortic dissections, we want to know what's the onset or origin, where's the location of the dissection, and it's classified as type A when the ascending aorta is involved, and type B when the ascending aorta is not involved. Or the DeBakey classification, type 1, the entire aorta from ascending to descending is involved, or type 2, just ascending, or a type 3 dissection, the descending aorta alone. Again, it's important to know ascending aortic involvement, or type A, are treated with emergency surgery, whereas type B dissections are initially managed medically. Incidence is about 2 to 6 per 100,000 patients, and 2/3 are male with a mean age of about 60 to 65 years old, with type A dissections being more common and affecting 50 to 60-year-olds more commonly, whereas type B dissections occur a little later in life and are more often related to hypertension and atherosclerosis. The pathophysiology of a dissection is an intimal tear where blood then enters into the aortic wall, leading to a cleavage plane which separates this aortic wall into inner and outer channels or true and false lumen. Some feel that a spontaneous hemorrhage of the vasa vasorum leads to rupture through the intima, with most favoring the primary intimal tear hypothesis. Why does an aortic dissection occur? What individuals are at risk? First, disorders that lead to abnormalities of the aortic wall. So looking at the microstructure of a normal aortic wall on this elastic tissue stain, one can recognize parallel sheets of elastic fibers, which are shock absorbers in the aortic wall. And in diseases where there's medial degeneration, abnormalities and fragmentation of the aortic media occur. So the elasticity and the strength of the aortic wall is lost, leading to risk of aortic dissection. And that's led to the terminology cystic medial degeneration. So some conditions associate with abnormal aortic wall, whereas other conditions associate with abnormal shear stresses. And easy to recognize is severe hypertension, or conditions with acute severe hypertension like cocaine, amphetamine use, or rare tumors like pheochromocytoma. About 70 to 75% of individuals with aortic dissection have underlying hypertension. When we think about conditions associated with dissection and abnormal aortic wall, first we characterize hereditary aneurysm disorders, some of which have outward recognizable features. We call these syndromic conditions, like Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos syndrome, with recognizable genetic mutations. Other conditions, and even more common, are non-syndromic hereditary aneurysm disorders. So these run in families and are recognized to be due to several genes, but don't have typical recognizable outward features of a syndrome. Let's start with Marfan syndrome as a typical syndromic feature that you might see in the emergency room in a suspect with concern for dissection. It's important to recognize the features, so you might think about dissection in these conditions. So I'll spend a few slides discussing each of the common syndromic features so you can help recognize them when they present in the emergency room. Marfan syndrome is abnormal fibrillin with an incidence of 1 in 5,000 people, often due to a spontaneous change, but it can run in a family where family members have it before the person you're seeing. And we make the diagnosis based on multiple features, the family history, mutation analysis, and clinical features such as very tall stature, elongated arms and legs, hyperflexibility, eye findings, things like that. So many times it's the skeletal features you recognize. These individuals are tall and thin with pectus deformities and scoliosis and can have hyperflexibility with the recognizable features as shown here. The person with Marfan syndrome often has an elongated face, downsloping eyes, small chin, flat cheekbones, and a very tall palate with crowded teeth and a small oropharynx. Marfan syndrome, of course, leads to aneurysms of the aortic root, and that's what puts them at risk for ascending aortic dissection, but also at risk for descending dissection. A majority have mitral valve prolapse. Another condition, less common than Marfan syndrome, which can share a lot of overlap in its phenotype, is Loeys-Dietz syndrome. But other features you might recognize are the presence of club feet, abnormalities of the skin, face, eyes, and mouth. And it has a characteristic triad, which we'll review, and tortuous blood vessels on imaging and aneurysms throughout the vascular tree. And that differs than Marfan syndrome. So someone with Loeys-Dietz syndrome can have bluish sclera, flat chin, prominent head or craniosynostosis, and can have abnormalities of the uvula. So take a moment to have your patients say, ah, when you suspect an aortopathy. And this can be diagnostic of conditions like Loeys-Dietz syndrome with a bifid uvula. The skin is soft and velvety with easily visible veins, and facial milia are more common in Loeys-Dietz syndrome. So look for abnormalities of the skin, the face, the skeleton, and think about this condition. Look for bifid uvula. Vascular Ehlers-Danlos syndrome is one of the rarer causes of familial aneurysm disorder, affecting about 1 in 50 to 100,000 individuals due to an abnormality in collagen. And typical appearance are sunken eyes with deep set eyes and dark coloration, a pinched nose appearance, attached ears, and abnormalities of the skin. Club feet are common, fingers that look old for the individual, named acrogyria, and very paper-thin skin with widened atrophic scars, easily visible veins, and varicose veins and abnormal bruising in young individuals should make one think of vascular Ehlers-Danlos syndrome. Much rarer than the common hypermobile Ehlers-Danlos syndrome, which does not associate with aortic dissection risk. So besides aortic dissection, aneurysms, and other arterial catastrophes are the hallmarks of vascular Ehlers-Danlos syndrome. So think about this condition in young individuals with arterial disease risk or having symptoms during pregnancy where there could be a risk of aortic catastrophe. Familial aneurysm syndromes or non-syndromic heritable thoracic disease is a common cause for aortic aneurysms. In fact, we recognize that 20% of individuals who have a thoracic aortic aneurysm disease will have another affected first-degree relative when one does careful screening. And this is without syndromic features. There's multiple genes that are now recognized as leading to familial thoracic aortic aneurysm disease or non-syndromic heritable thoracic disease. And these follow an autosomal dominant inheritance pattern. So when faced with an individual with suspicion for aortic dissection, ask, is there any family history of aneurysm disease, aortic aneurysm, cerebral aneurysm, or aortic dissection? And that should highlight and increase the suspicion for this condition in the person you're seeing. Bicuspid valve disease is common, mostly sporadic and isolated, but can associate with other conditions like coarctation of the aorta and Turner syndrome and can run in a family. Important to know is bicuspid valve is more common in certain aneurysm disease and is associated with abnormalities of the aortic wall. Compared to the normal flow through the aorta in a tricuspid aortic valve, bicuspid aortic valve leads to abnormal hemodynamics of the ascending aorta, leading to wall shear stresses, which associate with an increased risk of ascending aortic aneurysm and aortic dissection amongst individuals with bicuspid valve disease. And importantly, people who've had bicuspid valves removed remain at risk for late ascending aneurysm formation, and when that occurs, there's risk of aortic dissection. Turner syndrome occurs in 1 in 2,500 live born girls, associated with short stature, averaging under 5 feet tall when not treated with growth hormone, can have low set ears, lymphedema, webbed neck appearance, and delayed puberty or ovarian failure. Those are the typical hallmarks. And importantly, cardiovascular disease, including bicuspid valve and aortic dilatation, placing that individual at risk for aortic dissection, occurs in Turner syndrome women. So this is a group of people one has to recognize for this risk when cardiovascular involvement is present. In the absence of aortic enlargement or bicuspid valve disease, then aortic dissection risk is minimal. So remember that when evaluating a Turner syndrome woman for the condition of aortic dissection if presenting to the emergency room with symptoms of concern. Finally, other causes for thoracic aneurysms that can lead to dissection are degenerative aneurysms. These are atherosclerotic, associated with hypertension and other atherosclerotic risk factors, and are more common in the descending aorta and arch, and are more common in elderly individuals. Finally, amongst elderly individuals, giant cell arteritis can lead to aneurysm and risk for aortic dissection, as can other forms of arteritic syndromes. So in summary, aortic dissection is most commonly associated with hypertension. Think about the 20% of individuals with thoracic disease who have a family history. Some are genetically triggered with recognizable features called syndromic, like Marfan, Loeys, Dietz, and Veds. Others are non-syndromic. Bicuspid valve and other congenital syndromes associated with dissection risk. Trauma to the aorta, prior heart surgery, endovascular therapy like TEVAR and TAVR can traumatize the aorta. Atherosclerosis, toxins that associate with high blood pressure like cocaine and amphetamines, and inflammatory conditions of the aorta can all associate with risk of dissection. If someone has aneurysm disease, like Marfan or others, then pregnancy and weightlifting can associate with risk of dissection. In summary, aortic dissection is the most common cause in the aortic syndrome family, leading to disruption of the aorta, which can have life-threatening consequences. Risk factors for dissection we reviewed today include hypertension and conditions which affect the integrity of the aortic wall. Remember, aortic dissection often has an underlying genetic trigger, so screen first-degree relatives of the individual with dissection and ask about a family history when you're seeing the individual who could possibly have thoracic disease or aortic dissection. Those that have recognizable syndromes are at risk, as are those with prior aortic surgery and aneurysms. And when one recognizes these conditions that are associated with dissection, you can save a life when evaluating someone in the emergency room with an acute chest or back pain syndrome.